Hi, I'm Amerigo Rossi. I'm an assistant professor of exercise science at Long Island University, Brooklyn, and the president-elect of the Greater New York ACSM chapter, and I'm introducing Stephen Carek, MD. Stephen Carek is a family medicine and sports medicine physician in Greenville, South Carolina. He currently serves as the medical director for the Center of Family Medicine and is an assistant professor at the University of South Carolina School of Medicine, Greenville. His academic interests include resident and medical school education, quality improvement, and promoting physical activity in medical education. He has helped to create curriculum on incorporating physical activity in medical education at the graduate and undergraduate levels and has served as a faculty lead for the ACLM's residency curriculum. He is an avid runner, outdoors enthusiast, and aspiring cook who loves spending his non-work related time with his beautiful wife and 2 daughters. We're proud to present Stephen Carek, MD.
Hello, everyone. I hope you're all doing well. My name is Stephen Carek. I'm excited to be presenting with the Greater New York Regional Chapter of the American College of Sports Medicine. Today, I'll be presenting on the clinical applications of exercise and lifestyle medicine. And a big thanks to Irf Acid for his help and collaboration with this project. So before I start off, I want to tell you all a little bit about who I am. So I am currently in Greenville, South Carolina. I'm from South Carolina originally and grew up in Charleston. I went to undergraduate at Clemson University. I did medical school at the Medical University of South Carolina in Charleston, and then completed a family medicine residency in Charlotte, North Carolina with Atrium Health. Followed that up with a sports medicine fellowship at the University of Florida. And currently I serve as the medical director for our family medicine residency clinic, the Center for Family Medicine in Greenville. In my role, I help oversee and educate family medicine residents and medical students about primary care, as well as help oversee and help educate part of our lifestyle medicine curriculum. In that, I really have a passion for utilization of exercise as medicine and teaching the next generation of physicians the importance of exercise in their primary care practice. So before we take a big dive into the clinical applications of exercise, let's take a step back and let's look at the current state of healthcare. Currently in this country, I perceive that we practice more sick care. We promote or we focus on the treatment of disease. I would say we take a moment to think about what healthcare should look like. Instead of thinking about caring for the sick primarily, let's imagine healthcare where we try to promote wellness. We transition from that sick model to the well model. In this model, how should we take care of patients with chronic diseases? How would we change our mindset about relying on medications and procedures? And how can we make this transition practical, starting with the outpatient setting, and then hopefully be able to spread it across our community, across our healthcare systems, and be able to drive and promote well care, be able to empower patients to live healthier lives. Thomas Edison's quote is saying that the doctor of the future will give no medicine, but instruct his patient in the care of the human frame, in diet, and in the cause and prevention of disease. And this quote rings very loudly to me as I try to teach residents and medical students and all of my patients about the importance of disease prevention and the importance of lifestyle and the importance of the choices that we make day in and day out, and the behaviors that we practice day in and day out in order to help prevent as well as treat a lot of the diseases that we take care of. And that leads me into this sort of evolving field of medicine called lifestyle medicine. And what is lifestyle medicine? Well, lifestyle medicine is the use of evidence-based lifestyle therapeutic approaches like plant-predominant dietary lifestyles, regular physical activity, adequate sleep, stress management, and avoiding use of risky substances and pursuing non-drug modalities to treat, reverse, and even prevent a lot of chronic diseases that we see and care for. The most common of them being things like high blood pressure, heart disease, diabetes, anxiety, depression. And the aim is to transfer healthcare into a more sustainable model where chronic disease is managed and can be reversed with these lifestyle changes. All this research exists to help drive an evidence-based, value-based specialty that hopes to transform, redefine, and sustain health and healthcare by treating, reversing, and again, preventing these non-communicable chronic diseases. But why do we need this? As I said, leading cause of death in the United States, things like tobacco use, poor diet, physical inactivity, and excessive alcohol consumption are leading to the most common causes of death: lung disease, heart disease, certain cancers. And there's a huge foundation in health behaviors. These drive a lot of the evolution of these diseases, and these diseases have a huge healthcare cost associated with them. And effective motivation is incredibly difficult. A lot of these decisions are based on behaviors, and behavior is really one of the most difficult things to change in medicine. Allowing people to envision themselves living a healthier lifestyle or changing from their current lifestyle is just incredibly challenging. But developing these action plans and creating systems that can support these behavioral changes can be incredibly effective at reducing costs, reducing medication burdens, reducing overall disease burdens in patient populations and high-risk populations. And there's a huge body of evidence that supports using lifestyle medicine, or the principles of lifestyle medicine, in daily practice for things like high blood pressure, obesity, treatment and prevention of cancers, diabetes. Again, very common diseases that we see in outpatient medicine that can be prevented with changes in behaviors and changes how we approach management of these chronic conditions. And if we look at disease prevalence across the country for some of these major comorbidities, things like obesity, and in this map, the darker colors signify higher densities of the prevalence of these diseases. Things like obesity, diabetes, heart disease, cancers. There's a significant overlap. There's a significant geographic distribution. Myself, being in the Southeast, has an overlap with all of these pretty significantly. And one thing that's very prevalent is that lifestyle, or some of the lifestyle choices that people make, are closely tied to these disease prevalencies. So this map shows the amount of physical activity, so the darker blue representing decreased physical activity relative to the lighter colors, which is a greater physical activity. And it just shows how closely tied physical activity in particular is to the development and the prevalence of very common and very costly and very deadly and complex disease processes that exist in these areas. Overall, the burden of chronic disease and cancers, it parallels the distribution of physical inactivity in our country. And as I mentioned earlier, physical activity is a great tool. It can help prevent chronic diseases. It helps improve overall health, fitness, quality of life, and it can reduce the risk of these chronic conditions from progressing and allow physicians and patients to manage them better. It can target heart disease, type 2 diabetes, many types of cancers, including most common ones like breast and colorectal, help with patients with dementia and preventing further progression, help with very common mental health diseases like depression and anxiety. And you would think that if physical activity or use of lifestyle changes was so effective, it would be one of the most important things that you're taught in medical school. You'd think that the day you hit medical school, the first lecture would be on healthy diet, healthy exercise patterns, lifestyle choices as a way to treat and prevent disease. But that's just not the reality that we have in medical education right there. There's this huge gap in knowledge and implementation. And when we look at the different levels of training, starting with medical school, there's really only about 8 hours of required curriculum on average across the United States in identifying physical activity specifically and some lifestyle components. And when we think about the overall curriculum is a very small percentage of the total curriculum. The average medical school, you think of how many hours and hours and hours that students spend on things like biochemistry, genetics, very basic science, and how can we translate more of that more effectively into clinical science and clinical medicine. Deans, when they're surveyed, they feel that less than 10% of their school could actually write an exercise prescription upon graduation, which to me is just, it's out of touch with what probably our healthcare system needs, right? We focus more on the fundamental sciences, which are very important, but we also have to have an equal emphasis on clinical sciences and how we can better improve behaviors, improve lifestyle for our patients. When we take that to the next level, so following medical school, graduate medical education, residency programs, on average, residents only get about 2 to 3 hours of lifestyle education, didactics, and primary care. I mean, this includes things like obesity, nutrition, and physical activity promotion, which again, one of the most common things that a resident may see in their postgraduate education are going to be things like hypertension, diabetes, obesity, poor nutrition. And again, represents a very, very small percentage of the total didactic teaching. And why that is due to multiple reasons. One is just not common. Only 26% of residency programs, pediatric residency programs, have a curriculum in physical activity counseling. And there's numerous limitations, most commonly being just not having faculty that feel comfortable and competent in delivering that curriculum. And it's just they're not able to maintain it. But residents acknowledge that exercise counseling is incredibly, incredibly important, but they feel terribly ill prepared to deliver it and counsel patients. Almost every family medicine resident I know says that exercise is important. But if we were to survey them and ask them how they felt about their skills, they would almost describe themselves as incompetent in being able to promote exercise or counsel patients on exercise. And continuing on that theme, internal medicine residents, another primary care field, acknowledge that exercise and nutrition and lifestyle should be a part of their primary care visits. And only 14% felt they had the training to do so. We're just seeing this huge gap where medical residents know and identify that lifestyle is incredibly important to their daily practice, but we're not providing the infrastructure for them to learn and develop that competency. And when we tie that back, the knowledge and the acknowledgement, that physicians know that nutrition and exercise counseling are important, but a very small percentage feel qualified to do that. In the grand scheme, when 70% of diseases in this country are possibly preventable, and we're spending $2 trillion on healthcare in the United States, most of it which could possibly be preventable, we need to be building momentum in addressing this and trying to acknowledge that we need to do a better job of, one, training residents and training medical students and training the entire healthcare ecosystem in promoting lifestyle changes, things like physical activity promotion, to drive improvement in the overall health. Now, we know that we currently exist in this sort of sedentary epidemic. We know that there's a great correlation between physical inactivity and overall mortality. And part of building that confidence is just being able to guide the patient from the top left of this graph to the bottom right, getting from sitting to getting moving. And this is one of the most important things that we can counsel patients on, being able to empower them and engage them in behavior change to go from being overtly sedentary to being physically active. Now let's just quickly review the current recommendations for physical activity. And so there's two major components to the physical activity guideline recommendations that were put out in 2018. First is achieving 150 to 300 minutes of moderate intensity activity per week. And the second is incorporating strength training, muscle training, at least 2 non-consecutive days per week. But these are two major categories amongst other components of physical activity, things like flexibility training, balance training, bone strength, high intensity training, and the mind-body meditation. And these are the recommendations for adults. I do want to briefly touch on pediatric recommendations too. Remember, kids need 60 minutes of activity, moderate activity per day, and children ages 3 to 5, almost up to 3 hours per day. And so, we got to be able to counsel patients and first acknowledge this is where we want to be able to get to in order to promote an overall healthy lifestyle. And how do we get to that? What is the reasoning behind the 150 to 300 minutes of moderate intensity activity? When we look at all-cause mortality and self-reported physical activity and sort of graph that out, how much exercise per week do people report and what is their overall risk for death? Well, we see that sort of 150 minutes to 300 minutes is that sweet spot. Starting at about 150 minutes, we start seeing sort of a decrease in marginal return. And once we get to about 300, we start sort of flattening out at our relative risk reduction for all-cause mortality. And it's also sort of what's sort of perceived as a achievable amount of minutes per week that people can routinely and regularly exercise. We can probably maximize that, 600, 700, 800 minutes per week, but we just don't have as much significant return on that amount of time. And it just may not be practical for a lot of people to meet the needs of work, to meet the needs of their family, and exercise that much. But the other thing to make note too is that where do we see the biggest decrease in relative risk of all-cause mortality? And that's just getting people moving. It's going from doing no exercise to just doing some exercise. That first hour, we see almost a 20% reduction in the relative risk of all-cause mortality, which is huge. And if we can get patients to move, at least on this far left part of this curve, to go from 0 to anywhere from 100 to 300, that is a huge investment the patient can make in their overall health and well-being. And as I said earlier, just doing something, moving away from the sedentary lifestyle, and maybe not necessarily moderate to vigorous activity, but just being able to get up and get moving has healthcare benefits built into it. And this study was looking at the change in daily step count and cardiovascular events for individuals with diabetes, and shows that just increasing the steps by 2,000, 3,000, 4,000 steps per day can have as much as an 8% yearly reduction in cardiovascular event rate in individuals with diabetes, which is, again, another way to prevent the diseases that ultimately cause mortality in this country. Heart disease is the #1 killer in this country, and diabetes is a huge risk factor for cardiovascular disease. And being able to utilize just any physical activity, going from sedentary lifestyle to any amount of physical activity, is going to be an investment in that patient's health. But despite knowing that exercise and physical activity are crucial to improving overall health, we have really reached sort of a plateau in this country in the amount of people that are exercising and meeting these guideline requirements. This curve tracking the percentage of patients who meet the aerobic and muscle strength training guidelines for about 8 years looks pretty flat. I mean, we're seeing somewhere around 15% of females, 20 to 25% of males, and that's been pretty consistent for a while now. And we just haven't been able to move this marker a whole lot. And part of the reason why that is just incredibly challenging. Behavioral change, as I said earlier, is one of the most challenging missions in medicine, being able to take a patient from a lifestyle that they are used to, adjusted to, maybe enjoy in some way, shape, or form, and trying to transition them to a new lifestyle that's one possibly physically demanding or just different from what they're used to, culturally, socioeconomically, what they may be used to, is incredibly challenging. And it's also because, us as humans really exist in this fluid state of change. When we try to counsel patients on significant lifestyle changes like nutrition and exercise counseling, majority of patients exist in this pre-contemplative stage of change. And in this stage, we're really not acknowledging or really not ready to make a lot of those changes. And how, as we providers, can we move patients from that pre-contemplative to this contemplative stage of change, to where we're able to acknowledge that we need to make some lifetime change, but may not be ready to actually make that formal plan. And as provider, it's important to continue to promote a consistent message. So for my patients, always providing benefits of exercise, really probing about misconceptions about why this change may be difficult for them. Fears are a common thing, misconceptions, fears that patients may experience more pain, may not be able to reach the exercise threshold that they perceive, or maybe not even know that they can incorporate exercise into their daily lives because of other conflicts or other commitments. But again, and also try to have the patient visualize the benefits of physical activity, try to communicate with them and allow them to create a future version of themselves, try to probe them and ask them how they may feel or how their life may change if they were able to lose 10 pounds, able to walk a mile, able to compete in a 5K. And also try to tie in their social network, explore how inactivity could impact themselves individually, but also their spouse, significant other, their children, their parents, their siblings. See how their family would be able to support them and interact with them through this change. And it's important to continue to touch on these points, each visit being able to just see where they're at. understand what their motivation is, ask them on a scale of 0 to 10 how likely they would be to be able to make this change. And once they get to about that 7, say at a scale of 7 out of 10, I feel pretty ready to go, that's when we'll be able to transition to the sort of contemplative stage. In this stage, we still are trying to figure out what is going to work best for this patient, but at least the patient's able to acknowledge that they want to make change and that they need to make change to achieve a healthier lifestyle. But sometimes they may feel overwhelmed. They may say, Doc, how am I going to get to that 150 minutes per week? How am I going to be able to walk a mile? That just seems like it's so long. Well, it's really trying to build that idea of self-efficacy and emphasize that the importance of making small steps and trying to set realistic goals over a long period of time. And with that, allowing the patient to create their own plan and prepare to get to this preparation stage where they can develop a plan to meet goals and use goal setting to create a contract or a formal commitment to be engaged and to adhere to a program like an exercise program that they're going to follow with for the long term. And as a provider, you want to be able to reinforce them and reinforce that this is going to be beneficial to them, to help teach the patient self-monitoring techniques, build an environment with reminders. It's great to utilize people like within our clinic calling patients and seeing how they're doing with some of their exercise plans. In this age of virtual care, it's a wonderful way to connect with patients instead of having them come to the office every few weeks, being able to have a virtual visit or a telephone visit with them to see how they're doing, building in those reminders, building in the positive reinforcement and incentivizing them to adhere to a new exercise plan. And then once we're engaged in that plan, trying to maintain it. And again, this is another presenting challenges because there will be setbacks. You want to be able to identify opportunities where they may relapse, things like the holidays, or a great example where because of change in seasons or change in weather, of being a little more liberal with your diet, or maybe not having as much time to exercise, you want to be able to build in checkpoints so they can be able to you can be able to reinforce the plan that you have, the prescription that you've made, and try to help, again, reinforce that reward system to maintain motivation. All of these tie into being able to help a patient, drive them forward, empower them to create a plan, to identify ways for them to improve themselves, and then you as the physician support them and guide them and help them maintain that plan as they work towards a healthier lifestyle and engage more in that physical activity. But the thing too is always remember that patients do sometimes relapse, and that is you fall off the wagon, and it's your job as a provider to be there for the patient and support them through that. And again, sort of begin from the square one and can guide them back into the contemplative stage and help them prepare for their next attempt, and then guide them through another sort of phase 2 of whatever action plan you come up. And again, supporting them, being there to nurture them through this process. And again, working and spinning the wheel and slowly moving them forward as they are engaged and promote this behavior change. You mentioned, having some strategies too. What are the tools that we have available to us to help with this goal setting and self-monitoring? And we're so lucky that we have so many resources available to us that we just may not even know about. Things like fitness trackers, smartwatches are a great example that can set reminders and step goals, having patients engage in social media, whether it's Facebook groups or some sort of social media group where they can interact with like-minded individuals or individuals who have the same goals as they do, to be able to communicate and share stories. Having a health coach is a wonderful way. If you are fortunate to have resources in your community, like being able to connect patients with health coaches, it is a wonderful resource just, again, to provide check-ins and help guide patients through their journey. And the final is utilizing their support system around them, using their peers, their family members, again, trying to connect the patient with their social network is a wonderful way, because building that sense of community is very empowering, especially when we're trying to drive and promote behavioral change. And don't ever underestimate what you as a provider can do. Physical activity counseling is very effective. Just a provider acknowledging and counseling a patient on physical activity can increase the amount of physical activity that patient does, sometimes by 45, 50 minutes per week. And being able to create a structured approach to that can even reap even more rewards. This was a study that looked at physical activity counseling in a Spanish population where they were just given routine counseling, and some of them were actually given standardized education material, classes, and exercise prescription, and saw that patients sometimes increased by as much as exercise 130 minutes per week, which is just huge. And so don't ever underestimate your power as a physician or as a provider, a healthcare provider, to be able to improve someone's lifestyle or help them engage in lifestyle change just by acknowledging in the visit and counseling the patient about what benefits may come with physical activity. And now when we talk about exercise prescriptions, which is another fantastic tool that you can use in your clinical settings to help engage patients in exercise. I mentioned every visit we talk about prescriptions. We talk about medications that patients are on. Well, why can't we use exercise the same way that we use prescriptions and create a set rules, set algorithms, set process for them to be able to promote exercise and give patients the structure that they need to be successful? Y'all may have heard of the exercise prescription model, the FIT-VP model, which is a great acronym to help us write these exercise prescriptions. The FIT-VP model stands for frequency, how often you're exercising, intensity, how hard you're exercising, time, how long you're exercising, type, which type of exercise you engaged in, the volume of exercise you're doing over a week, and how we build that exercise prescription over time and progress. So current recommendations, in order to get to that 150 minutes to 300 minutes per week of exercise, we want to be able to reach about 3 to 5 days per week of moderate to vigorous activity. This is sort of the Goldilocks zone, sort of the perfect, because if we try to tell patients to exercise 6 to 7 days out of the week, well, that may increase their risk for injuries, especially if they're deconditioned or not well conditioned. And while 1 to 2 is a great place to start, we want to be able to get up to that 3 to 5 days per week. We do see some health benefits, like I said, with just going from doing nothing to doing something. But in order to have that sustainable, long-lasting cardiovascular benefit, we want to try to get into those levels where we're doing 3 to 5 days per week, again, to get to that 150 to 300 minutes per week of moderate intensity exercise. Well, how can we, counsel patients on intensity? We have a lot of terms that we use in exercise medicine for intensity, things like the Borg scale, utilizing terms like METs, and a lot of those terms are difficult for patients to understand or apply in their daily lives. So a great clinical way to utilize intensity is through the talk test. You'd have the patient say, or you tell the patient, I want you to exercise to a point where you can't really carry on a long conversation, maybe completing 1 or 2 sentences, but I don't want you to the point where you can't, say 1 or 2 words. It's probably too much. And if we can say that we can get someone to an exertion, relative perceived exertion of about 12 to 13, that sort of aligns with the moderate intensity exercise, and telling patients that, once they're at this, that's probably where we want them to be and be able to sustain that again for a period of time to meet that moderate intensity exercise, which has the beneficial cardiovascular benefits that we're talking about. How long should patients be exercising? So that time is, we want to try to get to that 30 to 60 minutes per day. Ideally in either one session or greater than 10-minute bouts over the course of a day. It's okay to break those up, but 10 minutes is probably about where we want them to be. Less than 20 minutes can be beneficial. Again, once we're starting patients off, setting reasonable goals for patients that are achievable is a great way to build that self-efficiency and build that confidence. But long-term, we want to be getting patients to about 30 to 60 minutes per day of exercise. For a lot of our patients who are obese, though, we do want to start expanding that out further. And for us to incorporate exercise as a good tool for weight loss, particularly in overweight and obese patients, we do want to recommend getting some longer duration exercise, 60 to 90 minutes, just to allow for more fat metabolism, being able to drive that weight loss, if that is a priority for our patients who may be obese and overweight. And the type of exercise that we recommend is really what the patient feels that they can do safely and do confidently. When we're talking about the types of exercise, we know there's so many options. And really the most important things to ask is, what do you enjoy doing? What do you have access to? And what's reasonable? The common place to start where things are just leisurely walking, leisure cycling, aquatic aerobics, so they have access to a pool. But you want to think of things that may promote some endurance, that don't have minimal skill. When patients don't have a history of playing sports or participating in regular exercise, just finding activities that they can do with someone else or in their community safely is a wonderful place to start. And walking, light jogging is a very sort of universal place to begin. And then once they develop confidence and once they feel supported, or once they may find other interest or a partner who may share in a different sport or a different activity, then beginning to drive those and incorporate those more so into their daily physical activity is a great thing to do. So if we were to put all this together and say, where do we want to start with a physical activity prescription, using that Fit VP model? If I were to see a patient in clinic and we were to have a conversation about incorporating exercise more into their daily lifestyle, well, we'd say, okay, well, I think a good place to start would be 1 to 2 days per week of brisk walking. You think about 3 miles per hour, or if we talk about sort of the breathe test, walking at a pace where you feel like you can complete 1 to 2 sentences if you're talking with someone with you. Not fast enough that you feel short of breath after 1 or 2 words, but not slow enough that you're having full conversations. Let's see if we can go for about 20 minutes per day. You can do 2 10-minute bursts before or after work, and try to do it outside. Walking outside would be a great activity to do. Let's see if we can get to doing this 40 minutes per week. And in the meantime, before we see you next in about 4 weeks, I want you to try to add 1 day per week, every other week until we follow up. And so this provides, a reliable structure for a patient to adhere to build off, to progress. And then when that patient follows up, the same way that we would check prescriptions, like, are you taking your Torvastat 40 milligrams once daily? You want to ask the patient, well, how's that exercise going? Are you walking 4 days per week for 20 minutes at a moderate pace? How is that going for you? Is it going well? Do there need to be changes? How are you feeling? And being able to tailor the prescription to the needs of the patient and continue to drive forward and try to build to that goal of 150 to 300 minutes of moderate intensity activity per week. It's also incredibly important to be able to tailor that prescription if the patient has underlying health issues. Diabetes is a very, very common one, where we have to consider things like what are the guideline recommendations for aerobic and resistance training, but 2, what are the possible complications that may arise with a patient who has an underlying disease process like diabetes. In particular, patients with high-risk cardiovascular risk, whether they either have known coronary artery disease, uncontrolled diabetes, having symptoms of chest pain with activity. Well, we want to make sure that we appropriately address that with the patient before engaging them in a high-intensity activity program. And so patients who, have high cardiovascular risk or have symptoms suspicious for cardiovascular disease like chest pain, shortness of breath with exertion, we really want to make sure we get those patients in to see a physician and have some additional screening done, like an EKG or a stress test, to be able to risk stratify, because we don't want to have an adverse event when we initiate an exercise program. We want to make sure that we do so safely. And with conditions like diabetes, we have to take in consideration other things with their disease processes. One example is patients with diabetes can develop severe neuropathy, and that may influence their ability to do certain exercises, may put them at increased risk for fracture and ability to do events that where they're on their feet for long periods of time. We have to worry about things like medications that they're on. If patients are on insulin or a class of medications called sulfonylureas that have a side effect of low blood sugar, we want to be able to make sure that we counsel the patient on the signs and symptoms or make medication adjustments if they become hypoglycemic or have low blood sugars, or even how to manage exercise if their blood sugars are excessively high. If they're greater than 250, what should they do to be able to exercise safely? Or when do they need to contact another medical provider before engaging in physical activity or exercise so they don't put themselves at risk for complications while exercise? Diabetes is just one example, but we have to make sure that for things like lung disease, certain cancers, certain patients on certain chemotherapy agents, for example, or patients with dementia, we have to be able to tailor that exercise prescription to their medical needs to promote safety, but also promote effectiveness of the exercise program that we want them to be engaged in. So with things like diabetes, incorporating that 3 to 7 days per week of exercise and moderate intensity activity, incorporating that resistance training as well, thinking of the secondary benefits, things like resistance training can improve insulin sensitivity and decrease blood sugars and help with A1C reduction, help with prevention of cardiovascular disease. So you always want to be able to weigh the risk and benefits. Ideally, and ultimately, exercise has way, way more benefits than risks for a lot of our patients, but we want to be able to acknowledge those risks and make sure that we try to mitigate them to the best of our abilities. And always think about the resources that you have available to you as well. You know, the American College of Sports Medicine and their exercise medicine program has a lot of great resources to give to patients. You know, here's diabetes again, where we can give patients some education material that helps walk them through the progression portion and help them understand what the recommendations are for physical activity to promote their overall well-being and their overall health. And so utilizing these resources for patients are great ways to get patients engaged, for them to do some reading and some learning in between visits, to think and plan about what an exercise program means to them and how they want to build a plan with activities that they like and how they can build a plan that helps improve their overall health. There's plenty of handouts of these for lots of disease processes. And so what I like to do a lot of times in clinical practice is just find the one that aligns with my patient's presentation is and go through it with them as a shared decision-making model and help create an exercise prescription for them that's tailored to their needs, that's tailored to their preferences, and helps and doesn't allow for complications to arise with whatever disease process that they may have. Now, the exercise prescription is a great tool to utilize in clinical practice. There's also the exercise vital sign. So the exercise vital sign is another great clinical tool to use to help screen patients and identify patients and monitor exercise progression over time. We're fortunate that within our healthcare system, we have the exercise vital sign built into our electronic medical record. So as part of a visit intake, for all of our patients, they're asked the simple questions of how many days per week do you participate in moderate to strenuous exercise? And on average, how many minutes do you exercise? And it's able to put out that minutes per week of exercise that we're looking for and trying to gauge where patients may be relative to guideline recommendations. And this is a wonderful thing to do because it can quickly identify abnormals. And two, it can also monitor over time, and this is something that we can track longitudinally. A great resource and the next step that we can take from the exercise vital sign is be able to identify patients at risk and connect them with resources that may be able to help them improve their physical activity and get them engaged in an exercise program. For patients that come in who fall outside of the recommended exercise and physical activity guidelines, we're prompted to provide educational material, handouts, and potentially referrals for patients to be engaged in exercise programs and utilize some of those similar exercises, medicine handouts that I was talking about earlier. If a patient comes in and say they're not meeting the guideline recommended exercise, physical activity duration per week, we can automatically generate educational material, again, talking about how we transition patients from that pre-contemplative to that contemplative stage and reviewing the benefits of exercise and helping the patient imagine what a healthier version of themselves looks like. If we can continue to reinforce that, we can hopefully shift them from that pre-contemplative to that contemplative state. And so here is what our screen looks like. If a patient's not meeting their guideline recommendations for physical activity, we can open up pretty quickly and pretty rapidly education materials to give to these patients that touch on things like exercising with anxiety, exercising with hypertension, exercising with COPD or diabetes or heart disease or heart failure. How do you lose weight with exercise? And so we can really tailor these materials to the needs of the patient, which just makes them a little more effective and allows the patient to make a connection that will hopefully empower them to make these changes. And if we get that patient from that pre-contemplative to that contemplative stage or that planning stage, and they're ready to begin the process of engaging and increasing their physical activity, we're fortunate that we have an exercise as medicine program where we can refer patients to local gyms, to local YMCAs, connect them with exercise professionals who are able to start that exercise program with them and follow them longitudinally and be able to build their exercise tolerance, build the amount of exercise or type of exercise they're able to perform, and do so in a safe manner. We're able to, tailor the exercise program to the needs and the presentation of the patient. We can tell the exercise specialist what conditions our patients have, what their limitations may be. Are any of their diseases controlled or uncontrolled? If they're uncontrolled, that sort of triggers another referral to be evaluated by a healthcare specialist or what the guideline recommendation may be for like a EKG or stress test. But it just allows us to individualize and tailor this exercise promotion, again, to the needs of the patient. And so with that, we're able to kind of take a three-step approach to improving exercise. So the exercise vital sign, screening and identifying patients who are adhering or not adhering to guideline recommendations. And then using these counseling techniques I've talked about in the exercise prescription, providing a focused intervention. And then if a patient either has significant comorbidities or feels that they would benefit from evaluation by an exercise specialist, we're able to refer them to treatment through things like Exercise as Medicine Greenville or local YMCAs or some other exercise programs such as cardiopulmonary rehab, which can be provide a structure and a support system and a group for patients to be engaged in and participate in and be involved and empowered to participate in, to again drive forward their health and allow them to live happier and healthier lives. And this is just within our clinical setting. And it's important to, at least my opinion, is to take your clinical setting and try to expand it out. Try to get other people to practice the same, to promote the same message and try to practice some of the similar strategies. And how are we able to do that? Well, it's in order to make programs like these sustainable, you got to be able to reach out and branch outside of the walls of your clinic. And with that, you want to make sure you're interacting with community partners, academic institutions, interacting with other physicians and other clinics and promoting exercise through things like continuing medical education. I mentioned one of the big gaps in education for residents is just not having faculty who just have experience or have confidence in teaching exercise promotion. So this is an opportunity for y'all to be that person, to be the teacher who teaches the next generation of teachers about the importance of exercise in clinical medicine. And then the final level, being an advocate for your patients, being able to drive public health and governmental support for promoting healthy activities and healthy exercise, to build sidewalks, parks, social programs that promote and drive physical activity as one of their pillars to improve and in better communities. And in Greenville, in upstate South Carolina, we've been able to build a pretty fantastic network of partners. I mentioned educational academic partners. In the upstate, we have the University of South Carolina School of Medicine, Greenville, which is where I work. We also have Furman University and Clemson University as academic partners. We have our healthcare institution, Prisma Health, where we have partnerships with our family medicine department, our orthopedic department, our oncology department, all trying to promote physical activity. We have partnerships with our community community organizations like the YMCA, as I mentioned so well, but also programs like Live Well, which is a social group that tries to improve lifestyle habits of the greater Greenville community. And our local county recreation department is another great resource to connect kids and adults into engage in healthy outdoor activities. And then we think about some of the national governing bodies that are helping drive development of curriculum, help drive outreach, help be advocates at both state and regional and national organizations like the American College of Sports Medicine, the American College of Lifestyle Medicine, the American Medical Society for Sports Medicine are all putting people at the table to help drive public health measures to improve physical activity promotion and the wellness of our communities. And so just to sum everything up, it's really important through this journey of promoting lifestyle that you have fun doing it, because, one thing that patients really look for or look to are healthy physicians. Patients really identify and will really respond well to physicians they perceive as living that lifestyle that they're trying to teach. So I tell all of our residents, practice what you preach. All of our med students, practice what you preach. And these are some pictures of us taking medical students to local kitchens where they're learning from chefs how to cook more whole food plant-based diets, or cook diets that or cook meals for patients who may have diabetes, heart disease. So creating healthy, delicious meals that are nutritionally beneficial for patients, but also getting them engaged in things like VO2 max testing, understanding what that looks like, engaged in physical activity programs. So make sure you always try to practice what you preach. And if this is something that you're interested in bringing into your own program, remember to try to incorporate with those around you. It's a team. And if the whole team can promote the same message, it just makes it that more powerful for the patients. So I didn't present these earlier, but I just want to go through. These are what I hope that you all leave here with some information on, and some food for thought, some opportunities for reflection. So I hope I was able to define lifestyle medicine for you, and what lifestyle medicine is, and how lifestyle medicine, the role that it plays in the current medical landscape. I hope you guys can see the gap in medical education and implementation of lifestyle and exercise medicine in the medical ecosystem that we currently exist in. And I was hopefully able to share some tools that, I personally use in my clinical setting that you all may be able to translate. Things like the exercise prescription, exercise vital sign, exercise as medicine, are all great tools to incorporate exercise as medicine into your clinical practice. And finally, I hope we can all share some ideas and solutions. I hope this presentation was able to start a spark for you in your own setting, and being able to help promote physical activity in your own clinical environment. And I would love to collaborate with any of y'all. If y'all have any questions on anything that I gave in this presentation, or have ideas that you would like to share, or share your own experiences, here's my email for you. Thank you all again so much for listening to this presentation, for coming to this conference. I hope you all enjoy it. I hope you are all safe. And I hope to be able to meet you all in person. So thank you again. I really enjoyed this opportunity to present this to y'all. And like I said, if you have any questions or any comments or anything that you'd like to share, please feel free to reach out to me. Thank you all. Be safe and be well.